Dear student, Assalamu alaikum. In this lecture we are going to discuss diabetes mellitus. Objective is to discuss the classification, etiology and pathophysiology of diabetes, to know clinical presentation, laboratory evaluation of the child with diabetes mellitus, and to discuss the management of diabetes mellitus, including treatment, monitoring and possible complication. Definition: diabetes mellitus, it is a common chronic metabolic disease characterized by hyperglycemia as a cardinal biochemical feature. Classification: first we have type 1 insulin-dependent diabetes mellitus. This is the main type in pediatric and characterized by random blood glucose more than 200 mg per deciliter, with a typical feature of diabetes. Second, we have type 2 insulin-independent diabetes mellitus. It is a consequence of insulin resistance occurring at the level of skeletal muscle, liver and adipose tissue, with a various degree of beta cell impairment. Patients do not have autoimmune destruction of beta cells. Typically, these patients are obese and presented with mild symptoms of polyuria and polydepsia, or are asymptomatic and detected on screening tests. Physical examination frequently revealing the presence of acanthosis nigricans, most commonly on the neck and other flexural area as shown in this picture. Lab tests reveal elevated hemoglobin A1C level, hyperlipidemia characterized by elevated triglyceride, and low-density lipoprotein cholesterol level. Third, we have other specific types, like genetic defect of beta cell function, genetic defect in insulin action, disease of exocrine pancreas, for example, cystic fibrosis, endocrinopathy, for example, Cushing disease, drug or chemical-inducing hyperglycemia, like steroid and thiazide, infection, for example, congenital rubella, and lastly, genetic diseases associated with diabetes, for example, Down syndrome and Turner syndrome. Etiology of insulin-dependent diabetes mellitus is multifactorial. First, we have genetic predisposition. There is a higher incidence of insulin-dependent diabetes is observed in children with human leukocyte antigen DR3 and DR4. Second, autoimmune response, evidenced by presence of antibody against the islet cells in about 80% of the patient, and association of insulin-dependent diabetes mellitus with other autoimmune diseases in some cases. Environmental factors. Viral infection, for example, measles, mumps, enterovirus, can be initiate insulin-dependent diabetes mellitus in a genetically predisposed individual. Pathophysiology. The main function of insulin are to reduce blood glucose by decreasing glyconeogenesis, glycogenolysis, and increasing uptake of glucose by the cell. It also leads to inhibition of fat breakdown and inhibition of protein breakdown. So, insulin deficiency will result in first, hyperglycemia. There is increased glucose in the blood above the renal threshold, which is 180 mg per deciliter, result in osmotic diuresis, polyuria, dehydration, and compensatory polydepsia. Also, we have increasing in proteinolysis, which lead to loss of weight, increasing of lipolysis with elaboration of free fatty acid in the circulation, and accumulation of ketone bodies, which result in ketonemia, ketonuria, and metabolic acidosis. Clinical feature: insulin-dependent diabetes mellitus has various presentation. The more common type of presentation as polyuria, polydepsia, polyphagia, and loss of weight, or may be presented with secondary natural aneurysms due to polyuria and UTI, or could be presented as insidious onset of vomiting, lethargy, and abdominal pain, or as a recurrent skin infection or vulvovaginitis in female, and lastly as a diabetic ketoacidosis in about 20 to 40% of newly diagnosed diabetic patients. Diagnosis: symptom of diabetes mellitus plus random blood glucose level equal or more than 200 mg per deciliter, 11.1 mmol per liter, or a fasting plasma glucose equal or more than 126 mg per deciliter, 7 mmol per liter, or 2-hour plasma glucose during the oral glucose tolerance test is equal or more than 200 mg per deciliter. General urine examination will reveal glucoseuria plus minus ketonuria. Hemoglobin A1C level is equal or more than 6.5, Other autoimmunity associated with type 1 insulin diabetes mellitus should be sought, including celiac disease by tissue transglutaminase IgA and total IgA, and thyroiditis by antithyroid peroxidase and antithyroglobulin antibodies. Treatment of diabetes mellitus. The insulin is the main treatment for diabetes, and we have different type of insulin that is vary in onset of action, peak and duration. We have rapid acting insulin, short acting insulin, intermediate acting insulin, and long acting insulin. This table will show different type of insulin with different onset, peak, and duration of its action. Insulin dose. Children with long-standing diabetes, there is no insulin reserve required about 0.7 unit per kg per day. If pre-pubertal, 1 unit per kg per day at mid-puberty, 1.2 unit per kg per day post-pubertal. Insulin regime. We have many types of insulin regime. For example, twice daily regime, either NPH alone or NPH with the soluble insulin. Thrice daily, soluble insulin given before each meal, or intensive 4 times per day, soluble insulin before each meal, plus NPH or glargine at the bedtime. We have also continuous subcutaneous infusion using a pump loaded with soluble insulin. Insulin administration. The site include abdomen, this is the fastest absorption and most preferred site, buttock, upper arm, the lateral aspect and interior aspect of the thigh. We should rotate the site of the injection around the selected area to avoid lipoatrophy and lipodystrophies. This picture will show different sites for injection of insulin. And this picture will show insulin syringe and insulin being used for administration of insulin. Insulin storage. Insulin in current use can be kept at room temperature between 15 to 25 degrees centigrade for a maximum of 28 days after the initial use within the expiry date. Avoid direct sunlight and area of temperature extreme, while unopened insulin can be stored in area of refrigerator between 2 to 8 degrees centigrade, where the freezing is unlikely to be happen. Monitoring of blood glucose. This can be done by daily monitoring of urine for glucose by use of strip. Monitoring of blood glucose by using of strip and device. Parents should be taught to use these devices and measure the blood glucose at least 4 times per day, before the breakfast, lunch, and dinner, and at the bedtime. Glycosylated hemoglobin every 3 to 4 months. Glycosylated hemoglobin, it is a reliable index of long-term glycemic control, and it is represent a fraction of hemoglobin to which the glucose has been non-enzymatically attached in the bloodstream. It is recommended that hemoglobin A1C measurement to be obtained 3 to 4 times per year, and the hemoglobin A1C fraction is usually less than 6 in non-diabetic patients. Value between 6 to 7.9% represent a good control. Value between 8 to 9.9% represent fair control, while a value of 10% and more represent a poor control in diabetic patient. Diet regulation. Regular meal plan with caloric exchange option are encouraged. 50 to 60% of required energy should be obtained from complex carbohydrate. We distribute the carbohydrate load evenly during the day, preferably by 3 meals and 2 snacks with avoidance of highly refined sugar, sweet and carbonated beverage. We encourage low salt, low saturated fat, and high fiber diet. We have a special consideration. First, dawn phenomena. It is thought mainly due to overnight growth hormone secretion and increased insulin clearance, which result in early morning hyperglycemia. Treatment by increasing the dose of night intermediate insulin. We have also Somogo phenomena. There is a late night hypoglycemia, which stimulate counter-regulatory hormone, lead to early morning hyperglycemia. Treatment by decreasing the dose of night intermediate insulin. Honeymoon period. Residual function of beta cell in the pancreas may be manifested by hypoglycemia, which occur after controlling of recently diagnosed diabetes treatment by temporary decrease of insulin dose. Management during infection. Infection may be precipitate hyperglycemia or even DKA. Mild infection should be treated and the dose of insulin increased by 10 to 15%, while in severe infection, hospitalization is necessary. Exercise. No form of exercise, including competitive sports, should be forbidden to diabetic child. A major complication of exercise in diabetic patient is the presence of hypoglycemic reaction during or within hour after the exercise. The major contributing factor for development of hypoglycemia with exercise is the increasing rate of absorption of insulin from the injection site, and also by increasing the both sensitivity of the muscle cell to insulin and increase in glucose utilization. Complication. First, we have acute complication like hypoglycemia, DKA, hyperglycemic, hyperosmolar non-ketotic coma, cerebral edema, and cardiac arrhythmia as a result of electrolyte disturbance like hyper and hypokalemia. Second, chronic complication like delayed growth, diabetic angiopathy, nephropathy, neuropathy, and retinopathy, and defective immunity with recurrent infection. Complication of the therapy like local reaction, lipoatrophy and lipodystrophy at the site of injection, hypersensitivity reaction, and insulin resistance, and usually this is due to presence of insulin antibody treated by increasing insulin dose. Let us discuss one of important acute complication of diabetes, which is hypoglycemic reaction. Definition: blood glucose value below 4 mmol per liter, which is above 70 mg per deciliter, in children and adolescents with diabetes. Presentation by hunger, nervousness, perspiration, dizziness, sleepiness, confusion, and irritability. Causes of hypoglycemia. The most common causes of hypoglycemia are inadequate or missed meal or snack, excessive physical activity, insulin administration error, vomiting and diarrhea, and lastly other medical problem like Addison disease and celiac diseases. Treatment: 5 to 10 grams of glucose should be given as a juice or as a sugar-containing carbonated beverage or candy, and the blood test checking 15 to 20 minutes later. For more severe hypoglycemia, therapy is injured and children should either unconscious or fitting, unable to swallow. Nothing should be given by mouth. Parents should be taught to administer glucagon by injection either subcutaneously, intramuscularly, or intravenously. When the child weight is less than 20 kg, we give 0.5 mg of glucagon. 1 mg can be given for children more than 20 kg. If no response in 10 minutes, we check blood glucose. If still low, we repeat it once. Follow up with carbonated food and frequent monitoring. In hospital, we can give intravenous dextrose 2 to 5 ml per kg of 10% dextrose, followed by 5 to 10% dextrose infusion to maintain blood glucose level between 5 to 10 ml. Another important complication of diabetes is diabetic ketoacidosis. Let us discuss the diabetic ketoacidosis as a clinical case. We have an 8-year-old male diabetic child presented to emergency department with 1-day history of vomiting, lethargy, and abdominal pain. His mother said that he does not taking insulin for the last day. Examination revealed fruity odor from his breath with rapid and deep breathing and disturbed consciousness level. Vital sign: normal temperature, heart rate 130, respiratory rate 30, and blood pressure 100/65. The weight of the child is 30. So, what is the most likely diagnosis? From the history and examination, the most likely diagnosis is diabetic ketoacidosis. Diabetic ketoacidosis is acute major life-threatening complication of diabetes. It occurs in about 20–40% of the children with newly onset diabetes. In DKA, we have a state of absolute or relative insulin deficiency which results in hyperglycemia, ketoacid, and metabolic acidosis. Hyperglycemia with the glucose more than 250 mg per deciliter, ketoacid with elevated serum ketone more than 5 milliequivalent per liter and urine ketone. And also we have acidosis with the bicarb level less than 15 and pH less than 7.3. Pathophysiology. Pathophysiology of the DKA. First we have insulin deficiency, which result in decrease in glucose uptake, hyperglycemia, osmotic diuresis, and dehydration. Also we have increase in proteinolysis with the elaboration of amino acid, result in more glyconeogenesis and glycogenolysis and hyperglycemia. We have also increase in the lipolysis with elaboration of a free fatty acid in the circulation, ketogenesis, and acidosis. And there is increase in counter-regulatory hormone, which lead to more glyconeogenesis and glycogenolysis and more hyperglycemia. What are the risk factors for development of DKA? First, we have infection. This is the most common cause in about 40% of the case. Psychological disturbance, a drug like steroid and thiazide, omission of the dose of insulin, and stress like trauma. In our case, the precipitating or risk factor for development of DKA is omission of insulin dose. Presentation. The clinical presentation of DKA includes symptoms like polydepsia, polyuria, weakness, weight loss, nausea, vomiting, and abdominal pain, while the signs include hypothermia, tachycardia, and tachypnea. Causal breath, we mean rapid and deep breathing, in addition to acetonic breath and change in consciousness level. What are the most important investigations to confirm your diagnosis of DKA? First, we have hyperglycemia, more than 250 mg per deciliter. Venous pH less than 7.3. The normal range is between 7.35 to 7.45. Serum bicarb level less than 15 milliequivalent per liter. The normal range is between 20 to 28 milliequivalent per liter. The serum electrolyte will show total body hypokalemia, hypophosphatemia as a result of osmotic diuresis, and pseudohyponatremia. In addition, we have hyperosmolality as a result of progressive hyperglycemia, impaired renal function test, glucoseuria and ketonuria on general urine exam. ECG may give the best indication for total body potassium deficit or chain. What are the possible differential diagnoses of DKA? The differential diagnosis of DKA including hypoglycemia, uremia, lactic acidosis, gastroenteritis with metabolic acidosis, non-ketotic hyperosmolar coma, CNS infection like meningitis, and salicylate intoxication. How we can treat this child? By fluid therapy, insulin therapy, potassium therapy, and to lesser extent by carbonate therapy. General management, we keep a flow sheet for the fluid, insulin vital sign and lab values, ECG monitoring for potassium change, urinary catheter if the patient is unconscious, and intravenous access for frequent blood draw separated from the fluid administration lines when hydration allowed. Start with the fluid therapy. In the first hour of the treatment, we give the patient 10 to 20 ml per kg intravenously as a bolus dose of 0.9% sodium chloride or Ringer lactate. From the second hour until the time of resolution of decay, we give the patient half normal saline. The rate of intravenous infusion calculate according to this equation. IV rate is equal to 85 ml per kg plus maintenance minus the bolus divided on 23 hours. The maintenance calculation for the first 10 kg of the patient weight, we give him 100 ml per kg. For the second 10 kg, we give the patient 50 ml per kg, and for all remaining kgs, we give the patient 25 ml per kg. So, the child weight is 30. In the first hour, we give him 300 ml intravenously on 0.9% normal saline or Ringer lactate. From the second hour until time of resolution of the DKA, we give the patient according to the equation mentioned previously. 85 ml multiplied by 30, which is the patient weight, plus 1750 mol minus 300 mol dividing on 23 hours, which equal to 175 mol per hour. The type of fluid is half normal saline, and typically we recommended that the glucose to be added as a 5% solution when the serum glucose has been decreased to less than 300 mg per deciliter, or as a 10% solution when the serum glucose has been decreased to less than 200 mg per deciliter, to avoid hypoglycemia. Children with mild decay usually recover within 10 to 20 hours, whereas those with more severe decay may require 30 to 36 hours with this protocol. Insulin therapy. Insulin infusion, we use soluble type of insulin, is given without any bolus dose at a rate of 0.1 unit per kg per hour. The aim is a gradual reduction of the blood glucose level by 2 mmol per hour, as a rapid reduction is dangerous. Potassium therapy. Potassium supplementation should be given to the patient as soon as urine passed. 20 ml equivalent per liter as potassium phosphate and 20 ml equivalent per liter as potassium acetate. The total is 40 ml equivalent per liter of fluid. If the serum potassium of the patient is less than 3 ml equivalent per liter, we give the patient 0.5 to 1 ml equivalent per kg as oral solution, or we increase the rate of intravenous potassium to 80 ml equivalent per liter of fluid. Bicarbonate therapy is rarely necessary and maybe even increase the risk of hypoglycemia and cerebral edema. Acidosis is usually self-corrected by fluid and insulin, and the bicarb therapy is indicated only when the pH is less than 7. This figure will summarize the treatment of DKA mentioned previously. Monitoring. Monitoring of the child with DKA should be include serial measurement of serum electrolyte and the blood pH, blood glucose, fluid balance, and urine output, the mental status of the patient, vital signs, and insulin doses. Blood testing should be done every 1 to 2 hours for children with the severe DKA, and every 3 to 4 hours for those with mild to moderate DKA. 10 hours later, the child develops headache, vomiting, drowsiness after a period of initial improvement. What is the possible cause of this deterioration in the patient condition? The complication of DKA includes cerebral edema, dehydration shock, hypo and hyperkalemia, and hypoglycemia. The causes of deterioration of patient condition is cerebral edema. So, cerebral edema, which is clinically apparent in about 1% of the cases of childhood DKA, and it is associated with high mortality and neurological morbidity. Risk factors for development of cerebral edema include excessive fluid administration, younger age, for example, infant and children less than 5 years, newly onset diabetes, severe dehydration at the time of presentation, severe acidosis at time of presentation, and treatment with bicarbonate therapy. Presentation include deterioration of the level of consciousness, nausea, vomiting, headache and pupillary change, seizure and incontinence, bradycardia and respiratory arrest when the brain stem herniation take place. The clinical signs are variable, may be presented as a gradual deterioration and worsening of consciousness level, or more commonly as a gradual general improvement, followed by sudden neurological deterioration as in our patient, and this will require a high index of suspicion, and it is most commonly occur 4 to 12 hours after therapy initiation, but may occur before treatment initiation. Treatment of cerebral edema include reduce the rate of intravenous fluid to less than 70 ml per kg per day, elevation of the head of the bed at least 30-degree angle, mannitol, which give as 1 gram per kg intravenously over 20 minutes, and may repeat it if there is no initial response in 30 minutes to 2 hours. Intubation and hyperventilation. Hypocapnia will cause cerebral vasoconstriction and reduction in cerebral edema. CNS imaging study, non-contrast CT scan, and treatment should not be delayed until the radiological studies has been obtained. This measure may be life-saving when initiated urgently before development of coma and maybe prevent neurological sequelae. When you are decide to transfer the child to oral intake and subcutaneous insulin, any child can be easily transitioned to oral intake and subcutaneous insulin when DKA has been resolved and there is no vomiting, no acidotic breath, the patient is fully conscious, the total bicarb more than 15 milliequivalent per liter, pH more than 7.3 with the normal electrolyte levels. For more information, you can be referred to textbook of pediatric and illustrated textbook of pediatric. And thank you for your listening.